Well, thank you very much again for this wonderful opportunity to present here today. And the cause of the presentation was the 10 Commandments, as we all do. And I believe I'm going to give you quite a similar views in my practice. So what I first do is to the patient evaluation. So I pay a lot of attention to the pre-admission clinics. One of the major stuff is that I always measure the leg length discrepancy, not only in supine position, also in standing position, because hyperlordosis or scoliosis or spinal conditions may change the spinopelvic situation and change the ability of the patient to walk. If the patient has got equal length in standing, don't try to correct a stiff spine, possibly. Of course, the pelvic obliquity and the tilt is very important, the fixed flexion deformity, the abductor muscle function, and the sciatic nerve function. Hip dysplasia, major issue in South Europe, previous surgery, previous osteotomies, both in the acetabulum or the femoral side. Previous trauma as well, metal work in the socket, metal work in the femoral side. And of course, high-risk patients for infection and DVT, hypercoagulability sometimes, so very high BMI. And the patient expectations, and of course, the patient cognition. If the expectations are enormous, you may start thinking of dual mobility. If the cognition is not wonderful, you may consider constrained liners. Templating. I don't have the luxury of the robotic surgery in hips. I do it in knees. So I manage with the 2D templating, but I always do it preoperatively because I need to know my inventory, I need to know my anatomy, I need to see how the implant is going to sit, and of course I need to know the level of the cutting of the neck so I can judge the leg length discrepancy. The approach. I personally go always posterior, and I do that preserving the piriformis. This is a piriformis preserving procedure. We've done a few thousand cases the last years, and I have observed that the well-known high risk of dislocation or higher risk of dislocation, the posterior approach, has disappeared. I believe this is a historic complication from now on, and this is attributed primarily to the fact that we use larger heads and we preserve muscles and especially the piriformis. Surgical technique, I start with a socket. However, if I'm dealing with a DDH or a deformed proximal femur and I'm going for an uncemented hip, I may start with a stem first, with a femur first, and then adjust my socket to have the expected combined version. When you're dealing with a cemented prosthesis, things may be easier because the cemented stems are more malleable and you can change version. It's not happening with the uncemented. So be aware of the deformity of the proximal femur. Personalization of my procedure. I personalize my procedure in relation to the center of rotation, to the patient's specific anteversion, which I take from the transverse acetabular ligament, and of course, I take into account the spine-hip relationship in a way I'm going to show you in a minute. This is a nice cartoon from Charles Riviere in his good paper demonstrating the fact. So for the spinopelvic evaluation, I take into account the sacral slope, in standing and sitting lateral position, the pelvic incidence, and the lumbar lordosis. And there is this algorithm on the right-hand side. We can see the sacral slope, which has been more than 10 degrees, and on the left-hand side, more than 10 degrees. So we have more stable situation, less stable situation, and we have balanced and imbalanced hips accordingly if you subtract from the pelvic incidence the lumbar lordosis. It's quite complex, but it's quite simple if you read through it. So you can reduce the anteversion if you have very stiff hips, or you can increase the anteversion if you have very mobile hips. There's more complexity with the papers coming up. This is a recent paper from Ottawa in Canada, from Grammatopoulos, which is talking about the combined sagittal index. I'm not going to go through this. I'm not using it in my practice, but I do use the spinopelvic consideration. With regards of the implant fixation, I do cemented and uncemented hips. I do hybrid hips and cemented hips for the females over 70 years of age with osteoporosis, and I trust very much the cemented hips. I do not rely on uncemented with a collar. I believe it's not a proven technique. And of course, when I'm dealing with a very poor acetabulum, I cement the socket in. Bearing surfaces. In my practice, the majority of the cases going for ceramic on highly cross-linked polyethylene. I have abandoned the ceramic on ceramic. I go for large heads if I can afford it, but I always take care of the size of the acetabular component to be over 52 if I want to use a 36 millimeter head. Rehabilitation. No precautions anymore. I send the patients home the next morning, and I use thromboprophylaxis using low molecular weight heparin. This is a recent paper from JAMA debating the aspirin, and I have no precautions. No precautions are needed anymore because we use large heads, 32, 36, and dual mobility when we worry, and it is not related to the approach. And of course, 4 immediate actions in my book. If I wake up the patient and see leg length discrepancy, I apologize and I don't send the patient home. I go to revise immediately. If I see nerve injury, very rarely, sciatic nerve, I go and explore immediately, probably in 2 or 3 days. If I see a periprosthetic fracture of the socket, I fix it immediately. I don't rely on screws. And if I see a leaking wound, within 15 days, I wash it immediately and don't wait for 3 months. Thank you very much.